Screen. Okay. Share. All right.
Yes, we can see your screen. You can start now.
Yeah. Okay, thank you very much. Let me just make it big. Okay. All right, this is going to be, inshallah, short and sweet. So it's going to be an introduction about interventional radiology. Radiology are two types. Either diagnostic, where you can see things with it, like X-ray, plain films, fluoroscopy, CT scan, nuclear medicine, ultrasound, and MRI. Or you can use those diagnostic tools to see inside the patients. And if you see inside the patients, you can use needles, catheters to guide them inside the patient in order to perform treatment for the patient. Okay, so this is the CT scan, and this is the picture it generates. Ultrasound, you all know. Fluoroscopic machine, you press on the pedal down here, and there is live X-ray. It shows you what's happening inside the patients. So you can use these tools again to see what's inside the patients. And we generally use in interventional radiology are needles. Inside the needles, you can put a wire, a sheath in the artery or in the vein. Through that, you can deliver a stent, which is this metallic tube, or the stent could be covered. Through the artery, you can go, for example, in the brain, if you have an aneurysm, and fill it with either glue, this one, or onyx, some sort of plastic. You can fill it with those coils. You can use particles, just small pieces like sand, gravel, and put it inside an area that you want to occlude. You can use balloons like this to open up an artery or a vein or a duct, a bile duct. Using different types of catheters and wires, you can guide these inside the patient. All right. So this is what we generally do is we can either remove a blockage or narrowing from the patient. We can stop the flow of the blood inside the patient. We can create access. I'll show you examples in a minute. And we can bypass abnormal vessels if they are causing problem. We can using those tools, we can deliver medications or local treatment, and we can use our catheters to take samples or pus removal. We can use this to give feeding. I'll show you one by one. And to remove the arteries, to remove the blockage, we can remove blockage in the arteries, in the vein, in the bowels, in the kidneys, in the biliary tree, and in the airway. So I'm going to show you examples of what we do. For example, this is a patient with an angiogram. You can see there's a catheter in the aorta. This is the common iliac on the left, external iliac on the left, but you can see here on the right side, it's an occluded vessel. Okay, now, so this is in the abdomen and pelvis. Now, these are both thighs. So this is the left thigh with a femoral artery on the left open, but on the right side, you have blockage from here to here. And this shows you that in the aorta here, we have a narrowing, okay? So in this patient, we open this up, okay, by putting a stent like this one. In the femoral artery, we opened it with a balloon, okay? And in the aorta, which is this one, that narrowing, we put a stent like this, and now this is open. Is that clear? Can you hear me? Somebody tell me if you can hear me.
Yes, doctor, we can hear you.
Okay, so it's clear what we've done, all right?
All right.
So
yes.
this is a balloon here opening up the narrowing and the stent opening up the narrowing. Okay, we can remove blockage almost anywhere in the body. Here is a pulmonary artery, right pulmonary artery, and there's a big clot inside the artery. And we can use mechanical devices like this one to remove clots from inside the artery. So pulmonary embolectomy. Alternatively, we can put a drug over here called Altiplase TPA, tissue plasminogen activator. And that can dissolve the blood clot from the pulmonary artery, and patient can get rid of his pulmonary embolism. Okay. We can remove the blockage in the biliary tree. Okay, this is a patient with, this is the intrahepatic bile duct. And you can see there is an area of narrowing. We're coming through the skin into the liver, into the bowel. So this patient has hepatico-jejunostomy. So this is a jejunum here, and this is the biliary tree. So this is left and this is right biliary tree. And we're coming with a catheter through the bile duct into the jejunum. And through that, this is a balloon going here, dilating it to open up the narrowing after transplant. We can do the same thing. We can cross the area of blockage. This is another patient. He has a blockage. First, they tried to put a plastic stent, and then the blockage recurred. And then there is another stent here, which is a metallic stent going from the common bile duct all the way down to the biliary tree. So we can open up biliary obstructions using balloons and using metallic and plastic stents. Is that clear? Any questions so far? So the way we do this is by, you see, by X-ray, by fluoroscopy, you are seeing what you're doing. By ultrasound, you can direct the needle inside. Okay. We can remove blockage in the renal system. So this is a patient. Do you know what this is? Anybody knows what this is? So this is called nephrogeratrostomy or double J stent, So this is in the upper collecting system. This is in the lower collecting system. Just give me a second, please. Hello, Dr. Badran. Yes. Okay, call Sultan and let him call me if he needs me. Okay. So, so double J stent. So if there is obstruction somewhere here by a stone or by tumor, by benign stricture, malignant stricture. So we're crossing the stricture with this tube, and the urine can pass freely from the top kidney to the bladder. Patient can void. This is another example, patient with hydronephrosis, so obstruction of the ureter. And this is a wire going through the calyx into the pelvis, and this is replaced with this catheter called a nephrostomy tube inside the pelvic calyceal system. So we are removing blockage to allow patient to pass urine. Okay. We can do this in the esophagus as well. So this is a stent we put in the esophagus for this tumor. So this is a stent after opening it. So we go through the tumor and then we open the stent. That will allow the patient to feed. We can use the same principle in the bronchial tracheal tree. So this is the trachea dividing into right and left main bronchus. You can see an obstruction here. And we help the patient by placing a stent within the trachea. Okay. So we were removing blockage. We can do that in the brain. So patients will sometimes, like this one, had a sudden stroke. And this is the internal carotid artery. This is the anterior cerebral artery. But if you notice here, there is no artery there. Okay. You can treat the patient by two methods. Either you go in and you aspirate the clot, remove it, or put a drug, which is this one, TPA, busts the clots, and most of the patients will recover immediately. So this is the artery, which was not there because of the clot, and this was removed. Okay. And that's another patient. So here is a clot, put wire catheter through it and remove. A catheter, give a patient thrombolysis, which is a drug busting, clot busting drug, and the patient improves. Okay, questions? So if you notice, we remove blockages in different parts of the body, in the vascular system, in the GI, in the bronchial tree, and so on. Okay, so the other way we could treat people is we can stop the blood from going to the organ. Whatever organ you have in the body, you can stop the flow to that organ. And we'll take examples on that. For example, this patient here, this is the bronchial artery. So this is a catheter coming from the aorta into the bronchial artery. And normally we don't see that this big. This is big. This is a patient with bronchiectasis. So we close this using particles, which are small, sand-like particles. So that will stop the bleeding. This is a patient with pulmonary arteriovenous malformation. So this is a catheter through the heart into the pulmonary artery, and you can see connection between the artery and the vein. And this is an AVM, arteriovenous malformation, and these are here coils to block one of the AVMs treated before. We can block it in patients with GI bleeding instead of doing surgery. So this is a patient with GI bleed. This is a catheter in the artery. You can see this is the hepatic artery. This is the gastroduodenal artery going down to the superior mesenteric artery. Okay, and you can see the connection of the gastroduodenal artery. And here, the patient had an aneurysm, and these are coils to stop the bleeding from that aneurysm. So, patient stops bleeding without surgery. Okay, and this is the patient, the bronchial artery before and after treatment, and this is the AVM before and after treatment. Okay. So we can stop the flow to the organs, not to stop the bleeding, but to make the organ shrink. So this is a patient with large fibroids. Patients usually have pain, swelling, pressure symptoms, bleeding. So you go through the artery. This is going from the right common iliac to the left common iliac to the left internal iliac to the uterine artery. And the inside there, we just put small particles. And what will happen for the fibroid is that with time, it will shrink. So this is an MRI showing the fibroid before and the fibroid after treatment. So without having hysterectomy or myomectomy, patient can have a good result. And as for the female, we can do the same thing. This is the fibroid compared with surgery. We can just do this with a catheter rather than with a needle, and catheter rather than with a scalpel. You can do the same thing in the prostate. So this is a catheter going inside the prostate arteries, and then we'll inject those particles inside, and signs of benign prostatic hyperplasia, BPH, will disappear or improve significantly after doing this. So the organ will shrink in size. We can do this for patients with bleeding. So this is a patient with a tumor in the uterus, and she had, if you notice here, a lot of packing in the vagina to try and stop the bleeding. And we do an angiogram, and you can see, although it is small, but this is persistent bleeding.
Don't go away.
Threatening the life, okay? So we put particles in that, and the patient stops bleeding, okay? So we saved life just with a catheter. We can stop flow to malformations. So this is here a patient with arteriovenous malformation, connection between the artery and the vein. And we can use different sclerosing agents, like you don't need to remember them, but polydocanol, sodium tetradicyl sulfate, bleomycin, alcohol, and so on. We can use coils, glue. So this is a catheter going through this lesion here in the soft subcutaneous tissues. So this is arteriovenous malformation, very highly pulsatile mass, compared with a venous malformation that just looks like varicose vein. And a lesion like this, you can just put needles through it and then inject it with one of those agents. And this is just one example of what will happen. This swelling here completely resolved. Okay, so this is blocking of supply, venous arterial supply in the vessel. This is a patient with arteriovenous malformation. This is the elbow, so this is the arm, this is the forearm, and you can see big connection. And here with the use of coils, glue, and alcohol, we block this connection between the artery and the vein, and now the patient has no pain anymore, and the arteries are without abnormal connections. So we are stopping the flow to the vessels. We can do the same thing with varicose veins. Okay, so this is a patient with varicose veins. Under ultrasound, you put the needle in the varicose vein and you inject one of the sclerosing agents. Or you can use laser, any of the ablation methods for the big veins like laser, radiofrequency ablation, or glue. You can go into the vein and go inside with a catheter, and then you can burn it with laser or radiofrequency ablation or block it with glue. And the end result will be fantastic, moving from a leg like this to a leg like that, from varicose vein like that to a significant improvement. Okay, so that was on stopping the flow in organs and vessels. The next thing we can help the patient with is to create access in the kidneys, in the liver. I'll show you as we go along. So this is the jugular vein, subclavian vein, innominate vein going into the heart. So we can go create a tunnel under the skin into the jugular vein and then put a catheter like that. This catheter depends on the type, like this one and this one. So this is a permacath, this is a Hickman line. So permacath like this one is usually used for dialysis. Hickman line like this one is usually used for chemotherapy. Or we can use the same thing, it's called the Picc line, this one. We can put it from the arm vein going up into the right atrium, and you can use this to insert drugs, withdraw blood, and patient can live with that for a year. So we are creating access to help the patient. This is access into the stomach. Okay, so we go percutaneously through the skin to the stomach, put a wire. Through the wire, put this catheter, and through this, patients who are unable to swallow can benefit from having fluids and food into the stomach. We can do the same thing if patient has a lot of reflux. So instead, like this one, instead of leaving this in the stomach, we can go all through the stomach to the duodenum, to the jejunum. And in this patient, put a catheter through the stomach, through the duodenum, to the jejunum. So this is the catheter. And that, there are different configurations. We do that if the patient has reflux from the stomach to the esophagus. So we are worried that patients will keep refluxing and aspirating. So instead of putting the food in the stomach, we are putting it in the jejunum. Okay. We can do the same thing for the large bowel. So using a catheter like this, which ends with a small button in the skin, patients who have fecal incontinence, usually patients with spina bifida and neurological problems, they have difficulty controlling the bowel. And what will happen, these people will soil themselves all the time. So instead of that, what you can do, you can decide, okay, I'm going to go to the toilet in the morning or in the evening. You sit in the toilet, you open this door, and you put a liter or two of fluid in the colon, and that will just flush the colon out. A patient will sit in the toilet and will pass the feces. So what will happen during the day is he will stay dry. Patient go out without any social embarrassment. We can create access in the liver. So this is a diagram that shows you, this is the liver. And the blood flow comes to the liver from the portal vein. Then it goes to the tissues of the liver. And as it goes back, it goes into the hepatic vein up to the heart. So people with portal hypertension, we can create an access we go from the neck, through the heart, through the hepatic vein. Then we put a needle, we puncture through the liver, then we puncture the portal vein. And after that, we put this stent. We put the stent from the portal vein, hepatic vein to the portal vein. And this is a picture showing the blood flow coming from the portal vein, bypassing the liver, going into the hepatic vein up to the IVC. And that will help reduce the signs of portal hypertension, like encephalopathy, like variceal bleeding, and will help that patient. Another access we can create is through the kidneys in people with stones. So this patient has stones in the renal pelvic calyceal system. So percutaneously and ultrasound and fluoroscopy, we can put a catheter. Then the urologist can come over and use this catheter to put a tube like this one, and through the tube, a scope can be inserted and the stones can be removed. The other thing we can do is bypass abnormal aneurysms. So this patient with abdominal aortic aneurysm, so this is the aorta, renal artery right and left. This is an aortic aneurysm, common iliac arteries. So we can This usually comes in 2 pieces. So this from here up to there is 1 piece. So we put this from the right groin. And there's another piece, which is this one. We come from the left groin and we put it inside, and we create an axis where we exclude the aortic aneurysm. And the same thing can be done in the thoracic aorta. This is the ascending aorta, the descending aorta with a stent, with an aneurysm. So this is a stent graft before and after opening. An angiogram shows you that this aneurysm has been excluded successfully. Okay, any questions so far? All right. The last thing is that we can deliver medications using our tools, like IVC filter, vertebroplasty, tissue ablation, and we'll just go through that and show you a few examples. Tissue ablation, there are many techniques, either through the catheter, you can do chemoradioembolization, you can deliver alcohol, you can deliver sound, it's called high intensity focus ultrasound, you can deliver freeze cryoablation, you can deliver heat, either microwave or radiofrequency ablation. And there's some examples. So this is a patient with multiple liver metastasis. We put a catheter in the hepatic artery over here, and then we inject the chemotherapy. So the patient has most of the chemotherapy going to the liver. You can significant improvement with less systemic side effects. This is a patient with IVC filter placement. Usually we do this to prevent clots from going to the lungs. So patients, for example, who had major trauma, car accident, he's got a DVT, and we cannot give the patient anticoagulation. So we want to prevent the clots from going to the lung. So we go either from the neck or from the groin, and then we do a venogram. This is the right, this is the left common iliac vein, this is the IVC, and this is a filter placed inside the IVC. We can remove it later if we need to. Okay. We can also deliver treatment to the bones. So these are the vertebral bodies. This is the patient with osteoporotic fractures. So you can put 2 needles through the bones, and through the needles we can inject cement. And you can use the same technique for this patient, for example, with bony metastasis. So in this patient, osteoporotic fractures, this patient with bony metastasis, this needle, you can heat it up to kill the tumor, and after you kill the tumor, you can inject cement to stabilize the bone. So here we're delivering treatment for osteoporosis and for bony metastasis using cement. You can do the same thing in the liver or the kidney. So these are radiofrequency ablation probes, or you can use also microwave. It's the same. They come with different shapes and configurations. You can go through the skin. So this patient, for example, has hepatocellular carcinoma. Needles like this were placed, and the tumor is burnt. So treating the patient with cancer only with a needle. Then we can take samples. So for example, this is a patient with a lymph node. And if you notice here, this is the sternum, this is the internal mammary artery, this is the aorta, this is the pulmonary artery, right and left pulmonary artery, and here we are placing a needle between the sternum and the internal mammary artery, away from the lung, into the lymph node, but avoiding the aorta and the pulmonary artery. This is under CT guidance. Under ultrasound, you can see this is a liver metastasis. We're putting a needle through the skin to the liver, to the metastasis, and taking a sample for biopsy. And this is a patient with an abscess next to the liver. This is under CT. You can see the needle going into the abscess, avoiding the stomach, avoiding the liver, and then you put a wire, and through the wire, you put one of those catheter, and then you remove the abscess fluid. So in summary, interventional radiology, people love it because it works. It's a very minimally invasive procedure with significantly less mortality and morbidity. And it replaces, or it's an adjunct to surgical procedures. Most of the cases are day cases. So that will help in patients turnaround in bed crisis. There's less need for general anesthesia, less need for ICU, less need for blood transfusion. It's very well tolerated by the patient. There's much less disruption with the lifestyle with just small incisions. And there is, because of smaller incision, there is less risk of infection. Thank you very much. The future is now. The future is interventional radiology. Any questions? Hello? Any questions?
No, thank you, doctor.
I told you it's going to be short and sweet, so it's been half an hour.
Yes, almost.
Any questions? I have a question for you. Who would like to be interventional radiologist? Okay, if you're interested, or you'd like to see at least what we're doing, you're welcome to Interventional Radiology Unit, Level 2, opposite to B1, King Faisal Hospital. Okay? I hope to see you in person very soon. Assalamu alaikum. Bye-bye.
Thank you, doctor.
Bye-bye. Shukran.